So great questions. So the good thing about rheumatoid arthritis is we know that any aggressive treatment or any treatment at all is better than no treatment. So there are a host of medications and therapies out there. As I mentioned before, they could be steroids to start or bridge therapy, while the patient is trying to get on medications, because some of these other therapies take a few weeks to work. They're disease modifying agents. And there's so many biological therapies. So these therapies, whether they're given as pills or injections or infusions, target certain chemicals or cytokines that can increase inflammation in the body or also instigate other inflammatory processes. So there are many, many different types of medications. Now, how do I decide what's best for the patient? Well, every patient is a unique individual, and I have to take into account their history, their other comorbidities, whether it's lung disease, COPD, diabetes, anything, and really talk to the patient about the risk and benefits of every medication. For example, methotrexate is a disease-modifying agent, a DMARD, and that is a cornerstone therapy for rheumatoid arthritis. However, if a young female is trying to get pregnant or a male is trying to participate in family planning, methotrexate is a medication that would not be used because it's teratogenic. On the flip side, if it's a young person who likes to drink and go out every week and drink alcohol, again, methotrexate can affect the liver, and this may not be the best candidate. There are also other biologic therapies that may have some risk of malignancy. So usually patients with malignancies, I have to be really careful about which medications are appropriate for these types of patients. So really taking into account the history is really important, the age, and also the compliance issue. Will these patients be taking a medication or a pill every day? Do they want to take an injection once a week, once a month? So again, all these come into play. But the good news, as I mentioned before, is that there's so many biologic therapies out there. Fortunately for these patients, they have options. So whether it's a TNF inhibitor, again, targeting TNF alpha, whether it's IL-6 inhibitor or another co-stimulatory inhibitor, there are other options, and there are different targets for medications. Also keep in mind that combination therapy, so not one therapy, is usually better than monotherapy for most patients. So even if a patient's not adequately controlled on one medication, you can do combination therapy or step-up treatment therapy. It's always important to talk to patients about it and also give them information. So I always talk to them and give them information so they can read up on it and ask questions on the next visit.